hands of Tracy Wilson, who will do the introduction of our speaker, Dr. Nicole Rochester, on medical gaslighting, exploring emotional abuse and healthcare. And by the way, there'll be in our chat, there will be a document so that you can register for CME credit. Thank you.
Thank you, Dr. Dukas. Hello, everyone. Thank you so much for being here. Again, I am Dr. Tracy Wilson, and a recent graduate of our program here at Tulane School of Medicine in May. I have the pleasure of introducing our speaker here, Dr. Nicole Rochester, who I have the pleasure of getting to know and bringing here to you all. Dr. Nicole Rochester, she is a board certified pediatrician, TEDx and keynote speaker, and the CEO of Your GPS Doc LLC, which is an innovative company committed to eliminating health disparities and bridging the gap between health care providers, patients, and family caregivers. Dr. Rochester was inspired to start her company after caring for her late father and witnessing the complicated healthcare system from the other side of the stethoscope. And I'll tell you personally, the way that I ran across Dr. Rochester is because of one of her talks that she was talking about her dad. And this was before medical gaslighting actually had that kind of term that it has now. And my own personal experience with medical gaslighting, and I was hearing about her talk and my own personal experiences with medical gaslighting and my family's personal experiences around medical gaslighting. And so as I continue to kind of go through my career and actually start doing talks on medical gaslighting, when I got here and started doing my curriculum here and we had these talks, I knew that I needed to bring her to this institution so that we could have these conversations even more. So I'm excited to have her here. She is a Maryland native. Dr. Rochester obtained her undergraduate degree from the Johns Hopkins University, her medical degree from the University of Maryland School of Medicine, and is a clinical assistant professor of pediatrics at George Washington University School of Medicine. She is a member of the Alliance of Professional Health Advocates, the National Association of Healthcare Advocacy, the American Academy of Pediatrics, NMA, National Medical Association, and she's a proud member of Delta Sigma Theta Sorority Incorporated, and more importantly, she is a proud mother of 2 young daughters. So I'm excited to have her be in front of you all today. Please put your questions into the chat as she goes through her conversations with you all to talk about medical gaslighting, and we will hopefully get to all of your questions this afternoon. So I proudly present to you all Dr. Nicole Rochester.
Thank you so much, Dr. Wilson. I really appreciate that warm introduction, and thank you for facilitating today's event. I also want to thank Dr. Dukas and Dr. Offenginden for the invitation and just for all of the warmth that you have shown me, as well as the entire program. It is truly an honor for me to be here with you all today. So I am going to share my screen. As Dr. Wilson stated, today we are going to be talking about medical gaslighting, exploring emotional abuse in healthcare. I have no disclosures. Let me please state that clearly. And before we get into the body of this presentation, as Dr. Wilson mentioned, I have to mention my dad. I always try to mention my dad, who unfortunately is now deceased. He's there in the middle, flanked by his 4 daughters. And, I would not be here without my dad. Now, obviously, from a biological standpoint, that is true. But also, I would not be here presenting this talk to you had it not been for my dad, because it was that caregiving experience that Dr. Wilson mentioned in my bio that led me to leave a career in pediatrics that I loved dearly, that I never thought I would leave in order to serve patients and family caregivers in this way, in a higher level. And also, as Dr. Wilson alluded to, in preparation for this talk, I have to disclose that I was reflecting on the many experiences that my 2 older sisters and I had while caring for our dad, And there wasn't a term when I was caring for my dad. This was from 2010 to 2013. I was not familiar with medical gaslighting. And so it wasn't until I began preparing for today's talk that I really started to recognize that many of the challenges that we faced while caring for my dad were absolutely medical gaslighting. And I'm not going to go into a lot of details because I have other stories to share with you today, but suffice it to say that as I thought about just the struggles and the challenges that we faced, the times that we were dismissed and ignored, the time where I frantically ran to my office in the hospital where I worked to make copies of a notepad that my dad had kept by his bedside that demonstrated just an abrupt change in his handwriting and a desperate move to try to get the physician to rescind a discharge order. This was back when we were trying to tell the doctors that there was something wrong with our dad. Ultimately, he was diagnosed with vascular dementia. So there were so many instances of medical gaslighting that I had not attributed at that time. So I'm just very grateful for the opportunity to present today. So in terms of objectives, by the end of this talk, you will be able to define medical gaslighting and understand it as a form of emotional abuse, recognize how medical gaslighting contributes to health disparities, and utilize a framework to prevent and mitigate the effects of medical gaslighting. And just to give you a quick overview, I'm going to start with some definitions and some background with regard to medical gaslighting. I also will be sharing some stories from individuals who have been victims or targets of medical gaslighting. And I want to take this opportunity to thank each of those brave, courageous individuals for sharing their stories with me and giving me permission to share those stories with you as well. And then we're going to talk about a framework to prevent and mitigate the effects of medical gaslighting. And then my favorite part is the Q&A and the discussion at the end. So I do want this to be interactive. I encourage you, if there's an aha moment as I'm speaking or if something resonates with you or you have a comment, feel free to drop that in the chat. You can also put your questions there as well. And we will have some time at the end to engage with one another. So what is gaslighting? Gaslighting is defined as the practice of a person in power using manipulation to make another person doubt his or her own judgment or even sanity. It is defined as a form of psychological abuse and bullying. And interestingly, the origin of the term gaslighting comes from a 1944 movie by the name of Gaslight. This was a thriller in which a newlywed by the name of Paula moved into an old townhome that she had inherited from her aunt. And she moved there with her husband, who she had only known for about 2 weeks. And in the first few weeks of living in this old home, she noticed that the gas lights throughout the attic and other areas of the house were seemingly going on and off without her knowledge or without her doing it. And so she asked her husband, who basically convinced her that she was crazy. And in fact, what he really was doing was manipulating the lights and changing the intensity of the lamps and a lot of other manipulative tactics in order to ultimately get her to become insane. And his goal was for her to be committed to a mental health facility so that he could then take her inheritance. So that's the origin of the term gaslighting. And of course, it's gotten more popular, not just in the psychological literature, but in lay literature as well. When we talk about medical gaslighting, this is a form of manipulation in which healthcare providers make patients doubt their symptoms, their experiences, or their feelings. And so what does this look like? Many of you may be wondering, have I been a victim of medical gaslighting? Have I been a perpetrator of medical gaslighting? And so I just want to go through some examples. So one example of medical gaslighting is dismissing patients. When patients present to us with their complaints, with their concerns, maybe there's an exam, maybe not, maybe there's a workup, and then ultimately deeming that there's nothing wrong with this patient and leaving them with the impression that it's all in their head. There are other instances of medical gaslighting where healthcare providers incorrectly attribute medical signs and symptoms or concerns to psychological causes. So telling a patient, oh, you're just stressed out. And certainly this is something to note where we have an increased focus, awareness, and recognition of the social drivers of health, social determinants of health. And so many are obtaining this information more thoroughly, but then we can't weaponize patients with the information that we gather. So if we find out that they are having housing instability or they're having marital challenges, but they also are indeed presenting with medical complaints, we can't then use that information against them and blame those medical symptoms on stress. Not only are medical symptoms sometimes incorrectly attributed to psychological causes, but sometimes they are incorrectly attributed to coexisting conditions, such as obesity. And so a common theme, and you'll hear this in one of the patient stories that I share, is when patients who have obesity or who are overweight present with physical complaints, and it's just chalked up to their weight. And so them being told, oh, you just need to lose some weight. That is another example of medical gaslighting. And another example is this idea of refusing to order a workup or refusing to issue a referral for a patient on their symptoms because those symptoms have been dismissed. And sometimes we even will use language that will kind of blame the patient or scare the patient. So this quote here, if I order a bunch of labs, you're going to get a huge bill, issued as kind of a warning. Like, I don't think there's anything wrong with you. You seem fine. I don't think there's a need to do a workup. And in fact, if I do, you're going to get a big bill. And then another example is disbelief, not believing patients. So this is very common when patients present with pain, and there are countless examples when in patients with chronic pain disorders, patients with sickle cell disease, where their physical appearance may or may not be congruent with what the healthcare provider thinks is consistent with someone in severe pain. And so looking at someone and saying, well, you look fine to me. So now that we've had a few examples, we need to talk about who is at risk for medical gaslighting, who's at risk of being a target. And in fact, anyone who presents to a medical or healthcare facility is at risk of being a target or a victim of medical gaslighting. But what we know from the literature is that there are certain populations who are disproportionately impacted by medical gaslighting, and that includes members of the LGBTQ+ community, women, older or elderly individuals, people of color, and those with stigmatized conditions, things like overweight, obesity, or mental illness. So when you research medical gaslighting, there's very little information in peer-reviewed publications. This is something that is poorly studied, and I would say it's an area ripe for research. And in fact, most of the information that you will find is in the lay literature. And so I wanted to share this particular article with you. This is from the New York Times. It was published a few years ago when doctors downplay women's health concerns. And the author states in her narrative of an episode of medical gaslighting that happened to her, well, you look like you're doing great, my primary care physician cheerfully informed me. I stared at her from the examination table in disbelief. I had just told her that I wasn't enjoying being with my children and was having trouble doing what needed to be done at work and at home. As a health journalist, I had interviewed dozens of physicians and psychologists. I knew that being unable to live one's life was the big red flag signaling it was time to get help. I was asking for help. But my doctor was under the impression I didn't need it. I don't think you're at the point where medication is an option. And anyway, it can be addictive. Keep exercising and doing yoga and maybe consider meditating, she said with a tight smile. Try to get some more sleep. I had just told her these very steps weren't helping, and anxiety was keeping me from falling asleep and getting restful sleep. But I began, she quickly interjected, if you're still having trouble a few months from now, come back and see me again, okay? Now, this is a real life story of a health journalist. So this woman, wasn't a healthcare provider or isn't a healthcare provider, but has intimate knowledge based on her career. And she shares this experience. And so having some knowledge about healthcare, she knew that something was wrong. She knew that this was not appropriate care. But she says later in the article that it took her several months to summon the courage to see another healthcare professional. Thankfully, this story has a happy ending. She saw a cognitive behavioral therapist and is doing much better today. So that's just one example. And we certainly know that there have been some highly publicized examples of medical gaslighting. And so many of you may be familiar with Serena Williams and her story. So Serena Williams, after giving birth to her daughter, Olympia, a few years ago, experienced shortness of breath. Now, Serena is also not a healthcare professional, but she knows her body. She is an Olympic athlete. And in fact, she had had pulmonary embolism several years prior. And so she recognized the symptoms that she was having after giving birth as being very similar, if not identical, to when she had had a pulmonary embolus. And so she did what any good patient does. She pushed her call bell. She called for the nurse. She let the nurse know that she was having shortness of breath, and she informed the nurse that I think I have a pulmonary embolism. And then she went so far as to say, I think I need a CT scan of my lungs. In response to Serena Williams' concerns, her nurse told her, quote, "You're not thinking clearly due to your pain medications." So Serena had to fiercely advocate for herself, insisting that the physician be contacted. And then when the physician was contacted, the initial plan of action was to do an ultrasound of her lower extremities, which was normal. And it was only with Serena's persistence that she ultimately got the CT scan that she originally requested, which in fact revealed the pulmonary embolus that she knew that she had. She was started on appropriate anticoagulation therapy. And of course, we know that this story also has a happy ending because she and her daughter are healthy. So, you know, if someone with her means, if someone with her notoriety is a victim of medical gaslighting, then we can only imagine what this looks like for other individuals who may not have that status. There have been some surveys about medical gaslighting. One was published in a 2019 study that showed that more than a quarter of women with chronic health conditions said a healthcare provider either ignored or dismissed their symptoms. Almost 1/3 of that same study population said they felt like they needed to, quote, prove their symptoms to a healthcare provider. 1 in 4 women surveyed with chronic diseases said a healthcare provider did not take their pain seriously. And a recent 2022 media survey showed that 72% of respondents, and these were female respondents, reported experiencing medical gaslighting, 72%. So again, I want to thank those who were brave and kind enough to share their stories. I posted on my personal Facebook page a while ago that I was giving this talk, and I basically asked my friends and followers if they had a medical gaslighting story, and if so, if they were comfortable to hop on a phone call with me and share that. So I'm going to be sharing one of those with you now, and we're going to call her Ariel. So the Ariel is a Black woman in her 40s. She contracted COVID-19, and in the acute phase of her illness, she experienced fever, chills, cough, lymphadenopathy, fatigue, and headache. Those symptoms improved, but then 1 or 2 weeks after having a negative COVID test, Ariel developed a head tremor, kind of like nodding yes. This was uncontrollable. This, of course, concerned her, and so she went to her local emergency department to be evaluated, not only for the head tremor, but also for some chest pain, chest palpitations, and headache. As part of Ariel's workup, the EKG was done that was normal, and the emergency room physician came in and literally said, quote, "I don't know what's going on, but we can't help you." He then attributed that her head tremor was due to COVID. Now, this was back a few years ago when we really didn't have a lot of information about long COVID. So we'll give him a little bit of a pass for that. But going back to what I shared earlier, this idea of attributing symptoms to a known condition. Now, what I didn't share with you is that Ariel is not only a Black woman, but she's also a physician, a very experienced OBGYN physician. And so she asked the emergency room doctor to order an MRI because she was very concerned about these symptoms, didn't quite understand how or why this would be connected to COVID. The emergency room physician told her that an MRI was not necessary and told her to follow up with her PCP. She did follow up with her PCP, who ordered the MRI, which showed some non-specific inflammation. And in the report, it was recommended that she follow up with an ophthalmologist and a neurologist, which her primary care provider facilitated, as well as referring her to a cardiologist. And now comes the second episode of medical gaslighting. So we'll call her Dr. Ariel. She went to her neurology appointment at a large local teaching hospital, and the first person that entered the room was the fellow. Now, Dr. Ariel shared with me that she was somewhat relieved because the fellow was a Black doctor, and we don't have time to get into this today. I talk about this in a lot of my other keynote presentations, but we do know that there are disparities related to the care of Black patients, and we also know that there are studies that show that racial concordance can make a difference with regard to not only patient experience, but outcomes. So Dr. Ariel was somewhat relieved when the fellow came into the room. And in fact, when the fellow examined her, he did note an intermittent head tremor. He goes out, likely presents to the attending who comes in. Incidentally, the attending is a white male physician. And he looks at her and says, okay, you're here for a head tremor. I don't see a tremor. In fact, the tremor was not obvious at the time that the attending came in. So the attending proceeded to tell Dr. Ariel that the tremor was because she was, quote, stressing out about the headache. So Dr. Ariel repeated out loud, so you're saying that my tremor is due to stress from my headache? And he said, yes. So this is when she disclosed that she's actually a physician. She's experienced a lot of stress in her career and has, in fact, never developed a head tremor. But in fact, she was actually dismissed. And when I asked her how she felt about this, she talked about feeling dismissed. She talked about feeling helpless. And in fact, her husband, who also happens to be a physician, was in the room, dressed in scrubs, dressed in an embroidered white coat, just in case there was any confusion as to what his background is. And this is something that many people of color, including myself, do often when we take our family members to the doctor. And so Dr. Ariel and her physician husband and the fellow began to now launch into a series of differential diagnoses, kind of going through some of the other options that this could be. So in fact, she had to participate in her own diagnostic process. As a result of speaking up and as a result of the advocacy from her husband and the neurology fellow, the attending did ultimately agree to order some tests, then looked at his watch and said, I've been in here 30 minutes, I have to go. Her headache was never addressed. There was no empathy in her words. He never even said, I hope you feel better. I'm sorry that you're going through this. And as bad as Dr. Ariel's situation was, what she said to me is, imagine how much worse this would have been if I was not a doctor. So as we continue to talk about medical gaslighting, we need to think about root causes. Why does this happen? How does this happen? And I believe, being in medicine for over 25 years and having lots of amazing doctor friends, nurse friends, other healthcare professional friends, I truly believe that none of us enter this field to harm. We all enter this field to help people. Yet we know that many of our patients are harmed. And so why does this happen? When we delve into root causes, there are root causes, and then there are what I like to call enablers. And so when I talk about enablers, these are the things that are part of our healthcare system, part of our structure and policies that enable medical gaslighting to happen in the first place. And one of those things is time. And I certainly don't have to tell many of you that time is extremely limited, has been shortened and shortened and shortened, so that the time that healthcare providers have in the exam room with their patients is frankly inadequate. It does not provide an adequate amount of time to get to know that patient, and even not enough time to often be able to get into the details of the visit, the details of their complaint. And we know that that limited time impacts patient trust, impacts their confidence, and certainly is a key factor with regard to medical gaslighting, as the example that I just presented, where the physician likely wasn't given 30 minutes and then lamented out loud that essentially the patient had used up all of his time. We also know that physicians today have a lot of competing priorities with the electronic medical record, with prior authorizations. There are a lot of administrative duties that physicians and nurse practitioners and PAs and other healthcare professionals are grappling with at the same time that they are in the examination room trying to provide great care. Another enabler for medical gaslighting is sometimes we just don't know. Sometimes there is a lack of information or knowledge. So the example that I just presented, early in COVID, we were all learning together. And so there are times when the healthcare professional really isn't aware of what's going on. And we all have egos and we all are trained to fix problems. And so sometimes that inability to figure out what's wrong with the patient, particularly when patients may be presenting with rare symptoms or something that doesn't necessarily fit into the proverbial patient box, that can lead to medical gaslighting, where instead of acknowledging that we don't know what's going on, we will gaslight the patient and try to make them believe that their symptoms aren't real or attribute them to other things. We also know that many of us, I'm assuming they're still teaching this in medical school. It's been a little while for me, but the whole horses versus zebras dogma, where we're taught if you hear hoofbeats, think horses and not zebras. And so this can play into medical gaslighting, where symptoms are attributed to an incorrect diagnosis that may in fact be more common. So those are the enablers. But if we really want to get to the root cause, at the root of medical gaslighting is bias. And so we know that all of us have implicit bias. These are the unconscious attitudes and stereotypes and opinions that we have about patients and groups of patients, communities, and groups of individuals. These are out of our control. And in fact, it's the way that our brain was wired based on all of the millions of stimuli that we are presented with every second of every day. And so those connections allow us to form patterns. And so while some of those patterns may be useful and adaptive, like recognizing immediately that a hexagonal red sign is a stop sign when we're driving, sometimes those connections and those patterns solidify stereotypes and things that we may have seen on television, things that we may have heard from members of our own family, things that we may have been taught from teachers, and things that we've observed over the years, stereotypes that are incorrect about certain patient groups. And so certainly there is evidence to suggest that this implicit bias is not only a huge factor in the health disparities and inequities that we see, but it also is at the core of medical gaslighting. And while we know that implicit bias is unconscious and unintentional, there also are studies that demonstrate that healthcare providers have explicit bias. One that I remember very explicitly was a landmark study published in 2016 that showed that white medical students and residents, that more than 50% of them endorsed false biological beliefs, things like Black patients have thicker skin, that Black patients have a decreased sensitivity to pain. And so when we begin to unpack all of this, we can begin to understand why patients of color and other marginalized patients have a higher incidence of medical gaslighting. Also, as we look at the root causes of medical gaslighting, it has to do with the systems and structures of power that are not only prevalent in our society, but also within our healthcare system. There is a dominant culture that is defined by patriarchy, by whiteness, by heteronormativity that pervades the healthcare system and the healthcare culture. And that is on top of the hierarchy that we already know exists in healthcare, whereby healthcare providers, clinicians, those of us who have spent years and years in medical school and residency and things of that nature are deemed to be more important, more knowledgeable than the patients and families for whom we care. So with that, I'm going to transition into the second patient story, and we're going to call her Tiana. And if you haven't picked up, I'm using Disney princesses. I love Disney. So Tiana is a Black woman. She is also a pediatrician and an adolescent medicine physician. And her medical gaslighting story takes place in the last year of her adolescent medicine fellowship. She was pregnant with her second baby. She had one healthy 4-year-old child at home and had suffered a miscarriage the year prior. Dr. Tiana was finishing up her last week of service before going out on maternity leave. It was the end of December. The holidays were approaching, and she was scheduled for a C-section in 6 days. On the day that her story begins, she had attended a combined holiday party and baby shower at work, went to Babies R Us to use her gift cards. And while at Babies R Us, she went to the bathroom and she noticed wetness in her underwear. Now, she jokingly told me as she shared this story that she had not laughed or coughed, so she didn't think that this was urine, but she actually did some investigative work and smelled it to make sure. And in fact, she says that when she smelled it, it did not smell like urine. And in fact, she described it as a, quote, fruity odor that she recognized as being possible amniotic fluid. It's important to note that Dr. Tiana had no prior experience with labor, as her first daughter was born via emergency C-section. So she didn't really know what labor should feel like, but she knew that she wasn't feeling any contractions. Also, in light of this, is that she was hoping to get through her last day of service the following day. Any of you who are physicians or other healthcare providers will recognize that we will go and go and go until we can't go anymore. And so even though Dr. Tiana had this concern that her water may have broken, she was highly focused on the fact that she had one more day of service and really didn't want to impose on her team. So what did she do? She went home, she fixed dinner for her daughter, she went to bed early. And then in the middle of the night, like many women that are pregnant at 39 weeks, she woke up to use the bathroom. But when she got out of bed, she saw a large wet stain on the bed. So she ended up driving herself to the emergency room. Her husband stayed home with their daughter. And when she presented to the ED, she told the clerk, "I think my water broke." She also told the nurse this. And of note, she said both of them laughed at her. One of them looked at her and said, "First baby, huh?" There was a lot of skepticism around her concern about her water breaking, but based on protocol, they did send her to the labor and delivery suite. When she got to L&D, she repeated to the labor and delivery clerk, "I think my water may have broken." And she says the clerk giggled and said, "Yeah, okay." So she told the clerk, "Well, I know a little something about this." She immediately recognized that she was being gaslit and was very angry. But at the same time, she realized that she was also hoping for a discharge so she could go home and finish her last day of work. So as she continued to reiterate her concerns about her water breaking, ultimately the nurse told her, "Well, I guess you bought yourself a little stay," as if she was being punished for coming in to be checked out. She later mentioned to at least 2 people during this hospital's visit that she was a pediatrician, as she said she grew sick of being laughed at and dismissed. While the nurse was evaluating her in the exam room, she asked Dr. Tiana to bear down, and no fluid came out. So this was, kind of preliminary evidence that, oh, maybe your water didn't really break. But again, following protocol, the nurse proceeded to call the OBGYN resident. Now, interestingly, Dr. Tiana, very similar to Dr. Ariel, stated to me that when the resident, who happened to be a Black woman, walked into the room, she breathed a sigh of relief. All of the previous healthcare workers had been white, and she thought, okay, here's some racial concordance. Maybe this is someone that's going to listen to me. But she also noticed that this Black female resident was in a noticeably bad mood. The resident told her to put her legs up in the stirrups, had her bear down again, and again, no fluid was expelled. And she says the resident goes, "Oh, fine, you're going to make me use the speculum." Now, this pediatric specialist, this adolescent medicine specialist, shared with me that she has gone to great lengths in her interactions with teenagers and adolescent patients to normalize the use of the speculum and to reassure them. And so this really struck her that this physician was almost threatening her with the need for a speculum exam. So she proceeded with the speculum exam and, in fact, did note a small amount of fluid during that exam. She told Dr. Tiana that it may be discharged, but she says, "Let me go look at it under a microscope." Several minutes went by, and as Dr. Tiana waited, the nurse came back into the room with an IV kit and says, "Glad you came in. You were right." Of note, Dr. Tiana mentioned to me that the doctor never came back into the room and that she just really felt, again, dismissed, ignored, very similar to what Dr. Ariel shared. She also stated to me, quote, "I didn't think I needed to protect myself from her," referring to the Black resident. She also noted, again, as a physician, that had she taken cues from the ER where she was laughed at and dismissed, and had she gone home, she could have developed an infection. She could have had prolonged rupture of membranes. Luckily, she did undergo a C-section several hours later and has a healthy daughter from that delivery. When I asked Dr. Tiana how this made her feel, very similar to Dr. Ariel, she said she felt helpless, she felt unseen. She says that she felt vulnerable and that she felt degraded. So, these 2 stories just really share the impact that medical gaslighting has on our patients. Our patients come to us for help. Our patients come to us as a source of refuge. And in fact, when they are victims of medical gaslighting, we leave them feeling afraid. We leave them feeling helpless. We sometimes leave them feeling hopeless. We have to remember that when patients present to the emergency department, the urgent care center, the hospital, and even outpatient practices, they are often having the worst day of their lives. And instead of being met with compassion, they are often met with disbelief and dismissal. So what is the impact of medical gaslighting on patients? Well, from a psychological standpoint, there is confusion, there is self-doubt, there is stress. It can either cause or exacerbate existing mental health conditions like anxiety and depression. And we also know that this can further exacerbate medical mistrust. When we look at the impact on patients, we also know that patients can become defensive and angry, noticeably and normally so. And so we have some patients who may retreat. We have some patients who may question themselves. And then we have some patients who may express openly their anger with the care that they are being received, which of course does not contribute to that therapeutic doctor-patient relationship. As I mentioned, there's a medical mistrust that results. And so if we look at the mistrust and the distrust that we see that was really highlighted, particularly in patients and communities of color during the COVID-19 pandemic, we can begin to understand the roots of that mistrust. And a lot of that comes from the way that patients and families are treated in the healthcare system as a direct result of medical gaslighting. This mistrust and distrust then leads to delays in care-seeking behaviors. It is why many times we see patients from marginalized communities waiting until what we believe to be the quote-unquote last minute to come to us to seek medical care for conditions that could have been more easily treated had they come sooner. We also know that there's impact on outcomes. And so due to medical gaslighting, there are delayed diagnosis, there's misdiagnosis, sometimes there's inappropriate treatments or therapies because conditions are incorrectly ascribed to other diseases and conditions. I mentioned that sometimes there is either an incomplete workup or no workup initiated as a result of medical gaslighting. And so again, these patients will often suffer as a result of this. And then we can't ignore that there are financial implications to this. So from the patient standpoint, patients who are targets or victims of medical gaslighting often are being seen multiple times for the same condition if they are brave enough to present again and again and again and to seek care from other providers. So there's an increase in out-of-pocket expenses for our patients. And then on the hospital side, there's decreased productivity, there's poor throughput. This is a contributor to increased wait times in our emergency departments and increased volume in hospitals, unnecessary volume for patients that could have been treated properly the first time. There are financial penalties associated with readmissions for some of these patients as a result of medical gaslighting and being ignored. And so we can begin to understand the broad reaching impact of this. It's enough that it impacts patients, but even beyond that, it impacts our hospitals and our healthcare systems. I want to make sure that to make this tie between medical gaslighting and health inequities, and these are just a few examples here. So there are unfortunately lots of studies in the pediatric literature with regard to health inequities among Black patients, and this regards to the care that is provided. And so one that I'll share here is that there are studies that show that Black children are more likely to have delayed diagnosis of acute appendicitis, and that Black children with appendicitis are more likely to have perforation. And this is directly due to their parents being ignored or dismissed, to the patients being ignored and not believed. We also know from studies that Black children with appendicitis are less likely to receive analgesia. So again, we've already talked about how medical gaslighting shows up with regard to dismissal and disbelief of pain. There are other studies that show that LGBTQ+ patients are more likely to report not being believed. They're more likely to report being dismissed or being blamed for their symptoms. There are studies that show that women with symptoms of heart disease are more likely to have them attributed to a mental health condition and less likely to receive appropriate therapy. And again, there's robust literature on the topic of women being incorrectly and late diagnoses and misdiagnoses for cardiovascular conditions. So I'm going to share my last and final patient story, and then we're going to kind of move into some solutions. And so this last patient story is Lilo. So Lilo is a Black woman in her late 20s, and she shared 2 medical gaslighting stories with me that I'm going to share with you briefly. The first is around irregular periods. Lilo shared with me that she's been having irregular periods ever since starting her menstrual cycle around the age of 11. She didn't really think a lot of it, but around 18 or 19, she started to ask her doctors about this. So when she would go for an annual checkup, or even in college, if she went to the college health facility, or if she would have her annual GYN exam, she would ask her doctors about these irregular cycles. Because when she was younger, the pediatrician had told her that this would likely correct on its own after 2 or 3 years. And what Lilo shared with me is that the doctors would always tell her, oh, well, your cycles are irregular because you're overweight. So just lose some weight and things will get better. What she shared is that there were no discussions with her about why being overweight caused irregular periods. The doctors never questioned her about her diet or about her activity. She says that she knew she was overweight, but she noted that when she started her period at the age of 11, she wasn't overweight. And in fact, for the many years, in those first few years of having cycles, she was not overweight, and in fact, had never developed a regular cycle. Lilo further shared with me that in the last couple of years, when she would bring this up, the doctors began recommending oral contraceptives, despite the fact that she had shared with them that she was actually interested in having a baby with her partner. She says that even now in her late 20s, she still has no idea what is at the root of the problem. One thing that Lilo mentioned to me is that the doctors never asked her or told her, well, here's a few other things that it could be. When I asked her how she felt about this, she said she felt sad, she felt angry, and she felt hurt. Lilo said to me, quote, "They're not trying to help me. They're just trying to put a Band-Aid on it." With regard to her being overweight, Lilo said to me, "I already know I'm overweight. What I would have appreciated was some advice, or even for the doctor to say, well, why don't you try to lose a few pounds and then come back in a month and we'll revisit it." She was struck by the fact that there was no plan and no follow-up. And Lilo further shared with me that this has absolutely impacted her desire and her willingness to seek medical care. She said to me, quote, "I'm not dying, so I don't need to go to the doctor to not be listened to." In her second medical gaslighting story, Lilo shared that while driving home from work a few months ago, the left side of her face began to feel really weird and kind of saggy. She initially brushed it off, but finally looked in the mirror and noticed that, in fact, the left side of her face was drooping. She woke up her spouse, who was in the car with her, who confirmed that her face did look weird. So she pulled over, her spouse took over the wheel. She called her mom and asked her mom for advice, and her mom told her that she should probably go to urgent care to get it checked out. Very reluctantly, because of the other medical gaslighting experience that I just shared with you, Lilo did go to urgent care, which was about a 45-minute drive. And by the time she got there, her symptoms had pretty much resolved. She checked in, paid her copay, and sat in the waiting room. And when she was called back to have her vital signs obtained, she said the nurse looked at her, asked her why she was there. And when she told the nurse said, "But it's not sagging now, right? There's nothing wrong. You seem fine." Now, Lilo had actually taken pictures of her face on her cell phone. And so she showed the nurse the picture so that she could see what her face looked like prior to getting there. She was sent back to the waiting room, where she waited for 2 to 3 hours and ultimately left without being seen. She said that this experience left her feeling dismissed, not believed, and unimportant. And I want you to reflect on the fact that Lilo is in her late 20s, has not yet had children, and how this has not only going to impact her willingness to seek medical care in the future, but because we know that women make the majority of healthcare decisions for themselves and for their family members, think about the impact that this is going to have on the health-seeking behaviors of her family. So as we wrap up and move to Q&A, I want to talk about solutions. I don't want to just paint this doom and gloom picture. So what can be done? Well, if there are any patients on the line, or actually all of us are patients, right? If we're not, we will be at some point. As a professional health advocate and the CEO of Your GPS Doc, I have developed what I call the GPS framework for navigating the healthcare system. And this is something that I use with clients. I use it with friends and family members and anyone who asks me for advice about how to get patients or doctors and healthcare providers to listen. And so this is the GPS system. And very briefly, the G stands for gathering information. This is the idea around asking questions. It is incredibly important that patients and families feel comfortable and confident asking questions in medical settings. The P stands for positioning yourself as the expert. And so while physicians and other healthcare providers have gone to medical school and residency and sometimes fellowships, and we have years of working as attendings under our belt, patients are in fact the experts for their own bodies, and family caregivers are the experts for those family members and loved ones. And so it's important that patients and family members feel comfortable positioning themselves as the expert. And what this means is correcting errors and making sure that they are heard when they are sharing their concerns about themselves and their loved ones. And then the S is for speaking up. This is that key advocacy piece that many, really all of the stories that I shared with you, they did it, they tried to speak up on their behalf. And we know that this is not always successful, but it is a core element for navigating the healthcare system, particularly when medical gaslighting is at play. This is just a brief reminder of the 4 principles of medical ethics, and this is something that we all need to be mindful of as we are caring for patients, and certainly as we think about medical gaslighting. So the principles of autonomy, beneficence, non-maleficence, and justice should absolutely guide each and everything that we do. There's a quote by Ralph Waldo Emerson: "What you do speaks so loudly that I cannot hear what you say." And when I read this quote, I think about my mom. You may think about your mom or your grandparents. That quote, actions speak louder than words. And so we need to think about, how can we act? What are some things that we can do as healthcare providers to mitigate and prevent medical gaslighting? And I developed this framework really directly informed by those heartfelt stories that I shared with you, and by the advice and the recommendations that the patients told me as they were sharing their stories. And so this is a clear framework. The C stands for curiosity. What this means is that we need to approach our patients with curiosity. We need to approach every clinical encounter with a genuine desire to get to know our patients. This is, and with clinical or cultural humility, which is not the same, I would say, as cultural competence. We need to understand what's important to our patients. The L is to listen. We need to listen to our patients, to their family members, to their care partners. We need to make sure that we are understanding their concerns, that we are not dismissing them. The E is for empathy. This is something that I feel is definitely lacking in the current healthcare system and in many of our encounters with patients. We need to demonstrate empathy. We need to humanize the patient experience. And I'm going to share with you in a minute a tool related to empathy. We need to acknowledge our biases. I shared with you about implicit biases, which all of us have, and the role that bias plays in medical gaslighting and in the way that we communicate with patients and families. And so we need to acknowledge those biases. While many of them may be unconscious, that does not mean that they are out of our control. And so we need to be very intentional about exploring the biases that we have about certain patients and patient groups. And then we also need to be intentional about interrupting those biases. And then the R stands for reasoning. And, several of the patients that were kind enough to share their story with me told me that they thought it was important that doctors share with patients why they think that something is not important, why they think that a headache is due to stress, as opposed to just dismissing the patient. And so when we're talking with patients, even if we feel that their concern is not founded, imagine what it would look like to say things like, well, I don't think it's this because of XYZ, or I've done these particular tests, or I've examined you And because of this is why I'm not concerned about the fact that you thought you were having a stroke. It's also important for us to weigh in with our patients and ask them, do you have any theories about what's going on, so that we can at least address the concerns that they came in with. This is me giving my TEDx talk a few years ago. And going back to empathy, I talked about my experience caring for my late father along with my 2 older sisters. And I issued a challenge, something I call the 90-second encounter, which is for every healthcare provider to spend the first 90 seconds of every healthcare encounter genuinely engaging with the patient. Before we get into why are you here, what brings you here today, just asking them about themselves, gathering a fun fact about them that will humanize them, but also humanize us. So I invite you all to watch that TEDx talk. You can scan the QR code that's shown there. I also want to briefly mention the hidden curriculum, because I know that many of us are involved with trainees, and I know that there are trainees that are watching. The hidden curriculum refers to the culture of medicine, those unwritten things that we are teaching medical students and residents and other students and trainees that we may not say, that they don't find in a book. And so for those of you who are responsible for learners, please don't ever forget the impact that your actions have, the impact that the things that you say to patients will have, because they will include this sometimes unknowingly in the ways that they will then engage with patients moving forward. And I want to end with advice from our patient experts. These are things that were said to me during those conversations. One of the patients said, think about your mom, your dad, your sister, or your brother when you're engaging with your patients. Another one said, see me as a human with feelings. One of the physicians said, remember the art of medicine. Remember the things that we learned back in medical school that were beyond the science, leaning in, sitting down, making eye contact, that empathy that we just talked about. All 3 of the patients said, listen to me, listen. This came up over and over again. One of them said, explain your thought process. And I just talked about that. And then one of them said very profoundly, realize that you are doing harm. And of course, with medical ethics principles that we just shared, non-maleficence, we are bound to do no harm. So with that, I want to thank you again. Thank you for having me. Thank you for your attention. I know we don't have much time, but I am able to stay a little later, and I'm really looking forward to engaging with you all. That's my contact information. I love to continue these conversations offline. So please feel free to follow me on social media, as well as LinkedIn, and my website is there as well. So I'm going to stop sharing, and Tracy, I'm going to turn, Dr. Wilson, I'm going to turn it back over to you.
Oh, it's fine, Dr. Rochester. Phenomenal conversation. This was amazing, as always. A couple questions that have come in, just want to get to maybe a couple of these. One question that came in around prior authorization. So can you speak to how the insurer's prior authorization process and rejection leading to having to file an appeal affects medical gaslighting? What are your thoughts around that?
Yeah, I will say that, as someone who was primarily a hospitalist in my career, and as someone who's not clinically practicing now, my heart goes out to those of you who continue to practice. And we certainly know that prior authorizations and dealing with denials and all of the other administrative tasks that have been placed on the backs of healthcare providers and clinicians plays a role. And really what I can say, I guess the question seems to go to the insurers and like the role that the payers have. And I believe that they need to be part of this conversation. We really need to have multidisciplinary conversations and discussions with regard to medical gaslighting. The solutions are not just going to involve the clinicians who are face-to-face with patients and families, but it is going to involve changes in policy and changes in regulation, perhaps even legislation. So I don't have like a solution to that problem other than to acknowledge that it is one of the many reasons that healthcare providers have less time with their patients, one of the many burdens and barriers. However, I'm not letting you all off the hook, because we still have to show up authentically for our patients, and we still have to listen.
Another question in regards to the movement. What are your thoughts as far as is there any movement around AI?
Yeah, you know, AI is an interesting issue. Certainly, even with regard to prior authorizations and some of the paperwork and documentation, there certainly are some opportunities for AI to relieve some of those burdens for clinicians. At the same time, there is some disturbing evidence that AI, depending on how it's used, can really kind of build in the existing biases that we know are present in our healthcare system. And so we have to be very careful when we begin to think about how AI can be used as a solution, because we know that there are structures and systems in place in our healthcare system, and even those interpersonal biases that I talked about, that fuel algorithms and that fuel the things that AI is learning from. And so in order for AI to truly be a solution in this space, we have to make sure that that it's free of bias and discrimination.
That's a really good answer there. This one I think is a really good question, especially with our conversation. What can fellow medical providers do to guard against being a perpetrator of medical gaslighting or approaching colleagues who may be medical gaslighting their patients?
I really, really, really appreciate that question. You know, I would start with the first part of the question: how do you avoid being a perpetrator? It's really the things that I just shared in the latter part of the presentation. And honestly, in my opinion, and I know that I'm simplifying this, but it really goes to restoring humanity, that empathy piece. You know, in spite of all of the challenges that you all face, in spite of the time constraints, in spite of the administrative barriers, we are bound to take care of our patients. And so finding ways to be able to show up in that manner is incredibly important. That 90-second encounter, I think, is so important because it just gives you that moment to just connect with your patient. Also, that advice about, you know, see me as your mom, see me as your dad. I think that when we are engaging with patients, if we are able to, as much as possible, just take a pause, take a deep breath, and think about, if this were my daughter, my son, my mother, my father, how would I engage with that individual? And I love the second part of the question in terms of how to engage with colleagues who may be, you know, doing or perpetrating medical gaslighting. And this is something that we talk about a lot in the DEI space and the health equity space. In general, we have to be allies. We have to be co-conspirators for our patients as well as our colleagues. And so we have to call things out, and we have to acknowledge, even if it's a colleague, even if it's a senior. So for those of you who are trainees, you know, I know this can be a little sketchy. It can be a little difficult, but as much as possible, even if it's in the form of an anonymous report, we have to make sure that we are protecting the patients that we are called to serve. And so I would encourage those of you in your respective institutions to look at whether you have a process in place where incidences of medical gaslighting or patient bias or racism can be reported by medical students, by trainees, by patients, by families, by colleagues, in a way that perhaps protects their identity, but in a way that that issue will be resolved. Because a lot of this may happen in the unconscious space, you know, I think that we can approach our colleagues with some grace, as opposed to approaching them, you know, with kind of a blaming spirit. But we have to feel empowered to reach out to our colleagues and to let them know when we see it. You know, say that when you see something, say something.
Actually, when I do this talk, that's what I actually say. I use the TSA, the TSA
Yes.
approach. See something, say something. One last question that just came in. The acute and worsening time pressures, which physicians, residents, I just say clinicians in general, are under, could contribute to medical gaslighting. What do you think about this?
It's absolutely true. It's one of the first things that I mentioned when we talked about the enablers. And, you know, again, as a physician who practiced for over 20 years, I can absolutely acknowledge that there are time pressures. And I guess what I am saying from the bottom of my heart is that, again, in spite of that, we still are doctors. We still are healthcare providers, clinicians. and our obligation remains to our patients. And so while the issues with the system are being worked out, and while we continue to advocate for changes in policy and things of that nature, we still have to be there for our patients. And so again, being creative in the ways that we do that, but not thinking that we can sacrifice the care that we provide.
Dr. Rochester, and you just even that talk that you said, that 90 seconds.
Yeah, we all have 90 seconds, right, you guys?
Exactly that. And actually, one of my classmates during my master's program, she actually mentioned that as well too. That 90 seconds, if we just give them that 90 seconds that's their moment. And they feel so seen and so heard. That can be so transformative in that relationship. So thank you for sharing that. So with that being said, thank you so much for sharing your time, your space, your energy in this this conversation, because it's so needed. And I think a lot of people are not understanding how important and how transformative it can be to saving our patients' lives. So
thank you. Thank you again for having me. Thank you, all of you, for your engagement. I'm looking at the comments. Thank you for the love that you're showing in the comments. Thank you for your questions and for your engagement. I'll be sure to read these after we're done, and go out and save lives, and don't leave your empathy at home. That's what I would leave you with.
Absolutely. We'll make sure that you get the chat on Dr.
Thank you so much.
All right. Thank you all. You all have a good and wonderful day.